something that I use in conjunction with many of the vascular surgeons that I work with in order to how to treat and a plan of approach for a patient. So we have a patient that comes in with critical ischemia and a non-healing ulcer, or someone who has rest pain. Let's say we get an MRA, a CTA, some invasive angiography, and it shows that a lesion, yes, it can be treated by an endovascular approach. So then I call on my vascular specialist, they do an endovascular approach. Then that's where I come in and my nurses to do wound healing, our infectious disease specialists and our medical doctors to do our atherosclerosis risk and factor modifications, which I will touch on a bit later. But let's say that with our MRA, CT, and everything, we are not successful. So the patient must proceed with open surgery, which does have risks. So if this surgery is successful, then great, we can do our wound care and then our risk stratification for these patients. But if it's not successful, then we do have to consider a primary amputation. And a lot of my amputations are staged. So I can do a primary amputation to control an infection and then involve my vascular surgeons, and then later go on to do a secondary amputation or whatever is needed, depending on the level of perfusion to the limb. So I usually do not discharge my patients from the hospital for quite a bit. They usually stay there for at least a week or so, even longer. So amputation. Any minor amputation, such as a toe amputation, a ray amputation, or a transmetatarsal amputation, does require adequate blood supply to the foot to maximize healing. And amputations are part of the treatment for gangrene tissue loss after revascularization. Minor amputations usually do not limit function and do not require prosthesis. Although preventing major amputation is the goal, amputations may be required for failed revascularization, patients with infection or significant tissue loss, and patients with contraindications to revascularization, whether it be age or just if they're extremely sick and can't undergo a procedure, and those that are non-ambulatory. It's important to note that up to 1/3 of below-the-knee amputations may require further surgery or an above-the-knee amputation due to poor healing. So our patients do need to be educated on this, because a lot of the times they feel like they're blindsided and that we're not on their side, and they just feel like we're being butchers, which we're really not. We really have to explain that and explain our expectations going through from the beginning. Also, a patent popliteal pulse, I cannot stress this enough, reduces the failure rate of healing to less than 10%. More than 90% of above-the-knee amputations heal, but only about 20% of amputees can regain their full mobility with a prosthesis when compared to 60% of those with a BK prosthesis. And factors related to poor prosthesis use and function after major amputation do include age, bilateral or above-the-knee amputations, dementia, and poor function before any amputation. Wound care. So our nitty-gritty. So wound care principles are aimed to improve perfusion to the limb, to treat an active infection, to avoid pressure of our wounds, debridement, to stimulate new cells and to trick our body into thinking this is a new wound so that our body sends all the signals to heal it, and also to provide appropriate nutrition to the patient. Debridement of devascularized or infected tissue is performed either by a scalpel, collagenases, or even maggots in some places, and they all can promote wound healing. Antibiotics can be required to treat an infection to prevent any osteomyelitis. Avoiding pressure on the wound is absolutely essential in wound healing. And if I can urge any nurse or maternal medicine doctor, whenever you get a patient in the hospital, please order offloading boots, because a patient may present with critical ischemia without any heel ulcers, but I promise you, during their hospital stay, many of them will develop a heel ulcer just because we didn't order those boots. So preventative care is our goal. Also, the temperatures of the limb can be increased by using these sheepskin boots to improve superficial collateral flow to the limb. So these are literally boots made out of sheepskin, and they're very warm, so they warm your limb and they increase or help to increase perfusion to the limb. And some hospitals actually do offer these. Negative pressure dressings like wound vacuums do increase capillary flow to help drain exudate from the wounds. Hyperbaric oxygen therapy can also be offered to improve wound healing, but it doesn't offer any advantages for amputation prevention. And additionally, products such as calcium alginates that are impregnated with silver, any povidone iodines, any other alginates that are derived from seaweed, some foams, hydrogels, and biologics such as our dehydrated human amniotic membrane allografts can be used as additional therapies. So up top, to the left of this, or to your left of the screen, you can see the sheepskin boot. To the bottom is our wound vac. Centrally is a calcium alginate, and this one in specific is impregnated with silver. Up top is our placental allograft. And then on the bottom there are the offloading boots that I'm urging everyone to order for all of our patients that have poor perfusion on admittance to the hospital. So medical therapy and surveillance after revascularization is just as important as before revascularization. Failure of any endovascular and surgical treatment of critical ischemia caused by a thrombus or progression of atherosclerosis does require close surveillance of these patients. Surveillance also includes an active approach to treating risk factors for atherosclerosis and to reduce the risk of any cardiovascular events. So patient education regarding health, diet, and exercise is absolutely paramount. Recurrent ischemic pain in the leg, delayed wound healing, and a decline in the ABI findings are indicators of restenosis or occlusion. A duplex ultrasound or bypass graft is commonly performed to identify the graft stenosis for revision cases and to preserve long-term patency. So low-dose aspirin is usually given lifelong to prevent a thrombus and to treat a segment. There is no consensus as what duration of Plavix, clopidogrel, to use to prevent occlusion of the segments treated by endovascular techniques. And most clinicians' trials of bare metal stenting and dual platelet therapy is usually prolonged for a duration of 1 to 3 months. However, data suggests that there is no consensus, so we don't know if longer treatment is required for peripheral arterial disease. A study's found that there is no benefit to adding Plavix to aspirin for graft patency. And patients with PAD who stop smoking have fewer cardiovascular events than those who continue smoking. This is obvious, but a lot of patients are not counseled on this and they really don't know that they have to stop smoking. Antiplatelet therapy with aspirin and Plavix and angiotensin converting enzyme inhibitors, all our ACE inhibitors like our lisinopril, decrease cardiovascular events in patients with peripheral arterial disease. And also our statin therapy consistently lowers cardiovascular events in patients with peripheral arterial disease than no statin or low intensity statins. So in patients receiving revascularization for PAD, statin therapy is associated with lower risk of cardiovascular events and limb loss. So differential diagnosis of critical limb ischemia. So acute compartment syndrome looks like this, and acute compartment syndrome is usually differentiated from critical limb ischemia in the fact that pulses are present and the patient has extreme pain and the pain is usually localized. But this kind of looks like that, and that is phlegmasia. And phlegmasia is when you have a deep vein thrombosis and a superficial vein thrombosis affecting your patient. But that kind of looks like these a little bit. So the one on the right is gout, which is localized, and usually the patients most likely have pulses unless there is a component of critical ischemia or PAD with these patients. And the one on the left is pernio, which is usually these little lesions of vascular insufficiency when a patient is exposed to cold or damp environments, but not freezing environments. When it's a freezing environment, that's when we classify it as frostbite. But these all kind of do present the same, and they can progress to the limb. Also, spontaneous hemorrhage or traumatic injury can be a differential diagnosis for any limb ischemia, but this is usually defined as an actual blunt trauma to the limb resulting in this hemorrhage, or antiplatelet therapy that causes the hemorrhage to occur. I only found it necessary to talk about COVID-19 dermatological changes since we don't have much information on this, and we don't know if we are seeing patients with COVID-19 changes, and they can have wounds due to this. So COVID-19 has been associated with a variety of dermatological presentations, including a viral outbreak of a rash, Livedo reticularis, any type of a rash, and petechial lesions, which are little ruptured capillaries, and also acral perneal-like lesions. On exam, patches of erythematous to violaceous skin are appreciated, and they can affect the extremities and other areas of the body. And this actually has coined itself as COVID toes. The lesion can correspond to focal areas of vascular occlusion, and the mechanism is unknown, so lots of work is in progress, but it does appear to be related to microvascular occlusive disease or an embolism. So microscopic intravascular thrombi have been seen on biopsy and examination of these lesions in critically ill patients. And some have hypothesized that dermatological lesions can be a clinical sign of systemic hypercoagulability. Yet acral lesions have also been reported in asymptomatic individuals along with those with mild cases of COVID. So we really don't know if our patients with COVID are presenting with these wounds due to COVID or other issues. So as I said, it remains unclear relationship between COVID and these lesions, and it is something to keep in mind. So the patients that we serve are pretty diverse.